Good afternoon. This is Bruce Pyenson, and we have two important sessions, one this morning and one this afternoon, that are going to look at the reimbursement and the management of radiology and general imaging and lung cancer screening. With me today is co-panel Director Anita McLaughlin. Anita, could you introduce yourself?
Hi, I'm Anita McLaughlin from the GoTo Foundation, helping out Bruce today with moderating, and I'll be working behind the scenes addressing any questions that come in online.
And I'm Bruce Pyenson. I'm a principal and consulting actuary at Milliman, and I just finished a 6-year stint on MedPAC, the Medicare Payment Advisory Commission, which is one of the topics that MedPAC does get involved with is recommendations on the physician fee schedule, which is one of the cornerstones of the Medicare program. With me today, we have two outstanding experts in the field of radiology and its reimbursement. Dr. Richard Frank, who is a leader, has been a leader for many years in reimbursement, policy, and regulatory issues related to especially imaging, and he now has his own firm. I'll let him introduce himself with more details. And also Zeke Silva, who is head of the AMA's RUC. And for those of you who don't know, the RUC is the key committee of the American Medical Association that assigns relative values for different procedures that are used for reimbursement and other kinds of purposes. I mentioned there's two related sessions, and I want to get at what we're going to try to do in each one of them before we begin the content. This morning's presentation is going to be at the pixel or voxel level for the imaging specialists. It's going to be very detailed on the components that go into the development of a CPT code's relative value and how much it's worth. So it turns out that there's a lot of discussion of always at meetings of this sort about how money is important for reimbursing procedures or innovation, and that's a very common theme in a lot of what we do. But there's actually a lot of detail, and maybe we could call it science, behind the establishment of the value and the reimbursement components for different kinds of procedures. And that's what we're going to be talking about this morning. This afternoon's session is going to be much more about population health, and on a much grander basis. We're going to hear presentations from individuals who are responsible for tens of thousands of lives, up to tens of millions of lives, organizations that are managing the radiology benefits and services to vast numbers of people, and how that happens. The two components, the microscopic and the grand population level, are intimately related, as we'll see. I hope you'll come to both sessions. The second session, of course, is after lunch. Without further ado, I want to introduce Richard Frank, and really, I think folks are in for some really interesting insight from both he and Zeke Silva. Thank you.
Thank you, Bruce, and I'd like to express my gratitude to the Prevent Cancer Foundation for this opportunity to present what really is a labor of love for me that's over the last 4 years to develop a taxonomy of AI to be used in the creation of code descriptors for reimbursement. Many of you will have come to know me over the last decade in my former role as Chief Medical Officer of Siemens Healthineers. I'm happy to report that I retired a month ago to become the principal in Frank Healthcare Advisors, and very happy to work alongside Zeke in the American Medical Association on the AI working group that led to the formation of this taxonomy. May I have the first slide, please? So the premise for this presentation is that patients don't really have access to the benefits of AI unless and until there's clinical integration of that and payment for the services and procedures that are conducted on behalf of physicians by this software as a medical device, as FDA calls it, or software as a service, as CMS calls it. So the framework that we developed, which is intended to provide descriptors which are discrete and differentiable in order to characterize the relative role of the work done by the machine relative to the work being done by the human. It was in 2018 that FDA finalized this guidance for software as a medical device, and it was realized that the terminology being used to form CPT codes may not well characterize this new category of product. Of course, computer-assisted detection devices have been around for 25 years, but those have not been reimbursable. And so it was important to understand that the field of AI was expanding dramatically to much more sophisticated devices. And in fact, it was only last month that the FDA updated their list of cleared devices, which now numbers about 350. And therefore, it was important to understand how best to describe this work. It was necessary to define the elements of work in order that we could have differentiation among AI services. And so we worked to incorporate the technical features and the performance of AI emerging for the foreseeable future, and we define that as being 2025. In particular, as that has an effect on the work of the physician and in order to enable valuation. And so what you see in the screenshot there is the AMA website in which Appendix S, which is this AI taxonomy, was accepted by CPT and was made effective from the 1st of this year. As you see on this slide, January 1st, 2022, provides this framework for discrete and differentiable codes, and they're intended primarily to characterize the interaction between the device and the physician. And there are 3 basic descriptors for this: assistive, augmentative, and autonomous. And I'll spend the next few slides explaining what those are. So the premise here is that by facilitating proper and consistent coding, the taxonomy will enable not only tracking of the procedures and services involving software, but also will foster patient, provider, and payer access to the benefits of this. Now, on the website, you will see some introductory information. One thing that's notable here is that we determined that the term AI was neither necessary nor sufficient, so this does not appear in the taxonomy. But instead, the 3 words, as I mentioned already, are assistive, augmentative, and autonomous. They describe 3 levels in the hierarchy of the work done by machines. The key meaning of the word assistive is that the device detects information which is clinically relevant. It does not draw any conclusions. It does not do any analysis. It simply draws the attention of the physician to things that are clinically relevant and leaves it to the physician to do the interpretation and the reporting. Augmentative not only detects, but analyzes and quantifies data in a clinically meaningful way. And that means that the output from this device should be directly and immediately useful to the physician in the care pathway for the patient. However, it yet remains for the physician to interpret and report this clinically meaningful information that the augmentative device has produced. Autonomous, on the other hand, involves, it describes the work done by a device which not only detects or analyzes or quantifies, but actually interprets the information. Now, there are 3 levels of this interpretation that qualifies for autonomy. The first level yet requires the physician to actually implement the information from this autonomous device. The second level, the device may actually initiate the implementation of the conclusions drawn from its interpretation of the data, and yet the physician may be required to fully implement that. And the third level, only at this third level, which you might consider full autonomy, does the device actually take action on its interpretation of the data. And this would be reversible by the physician, but it would require initiative on the part of the physician to reverse that. Now, in the description on the AMA or CPT website, there is this simplified chart to help people easily understand how their device might be categorized. And you can see here that the primary objective across the top, as I've discussed already, is detection, analysis, or interpretation. And down the left-hand side, you see what the output is. It either provides independent diagnosis and/or management decisions. The assistive device, no, does not do this. The augmentative device does not do this, but the autonomous device does, and therefore this is a key distinguishing feature. And you can see the logic as it flows through the rest of this chart, basically capturing in simplified form what I've described in the previous slides. And this is an even simpler way to understand it, that initially there's detection, the more advanced devices analyze, and beyond that there's interpretation, recommendation, and action. So how has this taxonomy been used so far? I'm really grateful to our keynote speaker, Dr. Tse, this morning, in providing all the granularity to the story behind the device for diabetic retinopathy. It's very important to understand the relationship between the output of that device and what has already been established as a clinically meaningful scoring system, the EDTRS. And on the basis of the performance of that product, which Dr. Tse rightly described as automated and detection, because those are the words that appear in the FDA label. Instead, given this taxonomy, it was possible to, shall we say, upgrade the description of this device. When the code had initially been applied for, Appendix S, the AI taxonomy, had not been accepted by CPT and therefore was not available to them in making their decisions. So when the code was first accepted by CPT, it included the word automated because that's all we had to work with at the time. However, after Appendix S was accepted and the word autonomous or augmentative was available to CPT as descriptors to be used in codes, they reapplied with another code change application, and the word automated was rightly, shall we say, upgraded to autonomous, because in fact that device not only reads the image, it not only quantifies the level of diabetic retinopathy, but actually interprets that relative to the EDTRS scale, which has a known association with the risk of blindness, and directly leads to the recommendation that comes out of the device, which is either, no, you don't have mild to moderate, and therefore you should come back to be screened again in a year, or yes, you do have mild to moderate retinopathy, and therefore you should be referred to an ophthalmologist. So this has been effectively a poster child. This device and this procedure has been a poster child for autonomy in diagnostic devices. Now, it's important to understand that not only is there the matter of labeling by FDA and the choice of words there, and descriptors in CPT codes, but also how CMS interpret the performance of devices relative to their willingness to establish coverage. And in the last round of rulemaking, they specifically asked this question: how do we recognize or how do we identify services that should be separately recognized as an analysis distinct from the imaging test? That is to say, it's not simply image reconstruction, and also distinct from the professional service. Yeah? And once again, we're talking about the work done by machines here. And so this has been flagged up by the National Academy of Sciences in a recent publication, and I would direct your attention to this. It's a very nice synthesis of the situation with AI in the United States in particular, and they too use IDXDR, shall we say, as a poster child. Now, the premise, once again, is that patients don't truly have access to the benefits until this is incorporated into clinical integration and clinical workflow, and there is payment for this. And so the framework, I hope you will see, provides the descriptors necessary for this discrete and differentiable coding in characterizing the relationship between the work done by the machine and the work done by the human. Now, CMS have established precedent over the past few years by virtue of decisions that they've made, and they do provide some explication for the decisions that they've made, and in particular, as they were deliberating the fractional flow reserve derived from CT, they initially interpreted this as simply image reconstruction or image processing, but they determined by a closer examination that a image processing service must either help develop the image or visually enhance the image, and it was determined that the fractional flow reserve CT service does not do either. It does something distinct and separable from that, and therefore it is not simply processing, and therefore it qualifies for separate payment. And so I feel that a harmonized lexicon would be ideal. Therefore, just as the word autonomous is useful in CPT coding, it might also be useful in FDA labeling with implications for the level of clinical evidence necessary to support that, but also with guidance to physicians for just what they can expect from that product. And you may know that there's been a recent letter to providers with regard to the triage software in which providers were relying too much on the output from that triage device. They were not interpreting the output as it's intended, which is workflow prioritization, but instead they were over-interpreting that as a rule in or a rule out and treating accordingly, which has significant risk of harm associated with that. And therefore, we think, for example, the lower level of the CPT coding, assistive, might be helpful to people to understand what they can expect in terms of the performance of products like that. And it's important, furthermore, to recognize that as CPT develop codes, initially there's a Category 3 code, which requires a certain amount of evidence and publications and so on. But in order for that Category 3 code, which is used primarily for tracking, in order for it to become a Category 1 code, which is generally associated with payment, it's necessary to have FDA clearance. And therefore, not only is there the binary question of is it cleared or not, but there will also, of course, be the issue of what is the label for that product. And all the more reason that there would be benefit to harmonization of the descriptors across labeling by FDA, coding by CPT, and then coverage and payment by CMS. And so I think that reference to the 21st Century Cures Act is relevant here. It's important to understand that there are exceptions to regarding software that should not come under FDA oversight, and that would be a separate issue. We're not talking about that here today, but in that Cures Act, they were careful to explain that there are certain categories of software which do come under FDA oversight, and that's what we're talking about here today. And so, my feeling is that the white space among labeling, coding, and coverage leads to confusion, whereas if instead we had a harmonized lexicon across the product codes that FDA issues, the taxonomy for coding, and then the coverage language in the physician fee service schedule would be very good for all of us. Now, there may be questions in your mind like why is automatic not appropriate, and other questions may arise. And so and in anticipation of that, we've actually submitted a publication, a manuscript to NPJ Digital Medicine, which has been accepted in principle, and Zeke and I are in the process of putting finishing touches on that, hope to have it out by the end of the year. So if you're interested in seeing that publication, or have other questions, you might follow the Twitter feed or also reach out to me as an individual. So thank you.
Well, thank you very much, Richard. And, the idea of harmonization between the FDA and CMS and AMA is certainly something that we've seen come up in many contexts, and is hopefully I'll get your comments on your view of the prospects for that. I'd like to hand the microphone over to Zeke Silva, who I think has by far the best title of any presentation you're going to see today. Zeke?
Yeah, thanks for having me. So, yeah, my name is Zeke Silva. I'm a practicing diagnostic radiologist. I'm in San Antonio, Texas, but I think I'm sort of most known, as was mentioned in the introduction, for being chair of a group called as I was saying, sort of known for chairing a group called the AMA's RVS Update Committee, which informs evaluation of physician services. But on a personal level, I sort of have the good fortune that every once in a while, my patients will ask me, they notice I look kind of young. I've even been asked recently if I'm still a medical student, and I thank my parents, particularly my mom, for that. But at the end of the day, I have to admit something to this group, is I'm really a dinosaur. And I hang around with a bunch of other dinosaurs. And I say that because the dinosaurs roamed the earth for millions of years, and there's a lot of different theories to why dinosaurs, they went extinct, and the research is ongoing. And for me, I spend considerable time in the fee-for-service space, which is basically per unit payment. And there's a lot of theories when fee-for-service and per unit payment is going to disappear, but it's still around. So I think as we come to a meeting of this sort, where, do I need to have the clicker to do this now? Or? Yes. Richard, can I have that, please? So as we sit at a meeting today where it's so innovative, we're thinking about these new solutions and these new directions around lung cancer screening, I think it's critical for us to understand the basic nuts and bolts of what fee-for-service is, because I don't think it's going anywhere anytime soon. So that's one picture of me, but this is really a picture of me, because this is a RUC meeting. So the RUC meets 3 times a year with the RVS Update Committee. There's 29 voting members, and the audience at any given time is 300 people. We meet 3 times a year. And as I run and I spend time with my group of dinosaurs, and we spend time talking about fee-for-service, I want to make a point here, and I want to make this point early, is the implications of what we do at the RUC are significant, but we're just making a recommendation regarding relative value. And we're making recommendations to CMS. What happens after that circumstance is transmitted is important. Coverage, outcomes, health policy research, payment. But that's not specifically our job at the RUC. But I do, again, want to make the point that I think it's relevant for we as a group to understand sort of what the RVU means. And money matters, particularly when you're talking about something with as much potential as lung cancer screening. The vast majority of lung cancer screening occurs in the outpatient setting. Sometimes that's the physician office, sometimes that's the outpatient hospital. I'd like to talk about both. And I like this image because when we talk about relative value units and we talk about total value units, I want to highlight what's happening here. And if you look at this image, it's pretty intuitive when you first see it. This is basically a patient-physician interaction. And the total RVU is work. So this physician is interacting with her patient. There's discussion about the history. Maybe there's talk about tobacco cessation within the context of lung cancer screening. But there's definitely a cognitive element to what the physician's doing. There's 3 kinds of light in this image, and I want to point all 3 of those out. There's sunlight, which I'm not actually going to talk about because thankfully as of today, sunlight is still free. But there's 2 other kinds of light. There's a light in the back. You'll notice it's kind of almost has a little magnifying element to it. Imagine for a moment that the physician's going to be doing a procedure, a minor office-based procedure on this patient. Well, that light has a payment. And I'm going to talk shortly about that payment in the context of a direct expense. It's CPT code, as Richard just alluded to, specific to the service at hand. And then there's light kind of above the patient, the utilities, if you will. That's an indirect expense, and I want to talk shortly about why that has implications for what we do. Now, that's part of what's called practice expense. That's the expense incurred by a physician providing specific services in their office setting. There's a malpractice component because there is some risk of liability anytime decisions of this nature are made, but I'm not going to talk directly about that. We're at a meeting focused on radiology, so let's look at that within our context. There's the work RVU, which for us is generally interpretation of an image, interpretation of a lung cancer screening exam. There's the practice expense, which we sometimes call the technical component. And when the PC and the TC are combined, that's a global payment. So what is physician work? And I think it's relevant for us to understand as we look at how we grade work on our relative scale. There's certainly mental effort and judgment. There's a psychological stress on the physician. There's time to perform the exam, and there's technical skill, and there's physical effort. All of these are factored into what we do at the RUC. Because it's easy to understand and because it's concrete, I find that time gets the most attention. For example, if a service increases in time, one could argue it should go up in value and conversely down, but it's not always that simple. And I think it's a fact that we need to ponder carefully. And when I interface with media, who, to be frank, is somewhat critical of the RUC, it's a point I often have to make is it's strictly relativity. It's not per unit time based. I've already introduced this topic. I'll touch on it briefly. When we talk about direct expenses, it's CPT code specific. It's lights, it's supplies, it's a number of these items, it's medical equipment, it's our CT scanners. But there's also this indirect, which, as I've already mentioned, is the utilities. It's not code specific. It may be the receptionist. Oh, by the way, it might be software. It may not. It might be hardware. It might be software as a medical device. These topics that Dr. Frank just introduced are very much in flux as far as how we're going to classify them, whether they're direct or they're indirect. I've already talked about how we're paid in the physician office after what's called the Medicare physician fee schedule, but I think it's important to acknowledge that the hospitals are paid differently for their outpatient services. They're paid through a system called the Hospital Outpatient Prospective Payment System, HOPS, or you'll sometimes hear it referred to as OPS. In contrast to what we do at the RUC, where we look at the direct resources, the direct cost to determine payment, payments vary differently determined within the outpatient prospective payment system. It is a prospective system, so every year CMS looks at the charges that facilities submit regarding services. So imagine a hospital outpatient does a lung cancer screening CT exam. They'll actually submit with their claim for payment, the amount that they charge for that service. And that'll include their staff, that'll include potentially equipment, that'll include gloves, NIV, which isn't necessary in this instance, but if it were, it might include that as well. CMS takes that data and every year updates what are called ambulatory payment classifications to make those payment determinations. Why it's relevant for our discussions here in a conference that's as forward-thinking and progressive as this one is it's all related. So when we talk about the physician fee schedule, it's sort of the bottom right of the screen, that's kind of what I introduced. But when we talk about hospital outpatient payments, which is at the other side of the screen, or we venture to the top where it's inpatient payments, all of this is related. And we learned this in radiology in 2004 through what was called the Deficit Reduction Act, where even though we have two payment systems that have developed in parallel, and the RBRVS, or what I do at the RUC, that system's been around for 30 years. So that is, in the scheme of payment systems, truly a dinosaur in the big scheme of things. But the hospital outpatient prospective payment system has been around since the early 80s, and they've developed in parallel different methodology, different inputs, different clinical indications potentially, and different providers and different data to consider. So it's not surprising that they would have developed in parallel, developed differently. So what we see on a practical level is payment differences potentially between one setting and another setting. And when they come together and they're interrelated, there could be a potential ripple effect. So I appreciate the opportunity. That was a lightning fast overview of payment policy, but I think it's critically important that we understand the nuts and bolts of how fee-for-service is determined so we can use that foundation and that basis to inform the type of innovation which we'll be discussing in this conference over the next 2 days. I appreciate the opportunity. Thank you.
Well, thank you very much, Zeke. That was a real enlightening presentation, very clear, what a clear presentation of what the RUC does, which I know can get very, very complicated. We have an open mic here for folks that are here physically, and questions being tabulated on the chat box for folks who are virtual, who are remote. I'd like to begin with a question for both Richard and Zeke, which is, the nature of a lot of the work that is done by the RUC and gets translated into the CMS, Centers for Medicare and Medicaid Services, it feeds into a zero-sum game. That is, if more money is paid for imaging, less money is paid for someone else and some other kinds of services. And I know a lot of the innovators want to get more funds going for their innovation. Who would you suggest should get less funds if advanced imaging and AI gets more? What are your thoughts on that?
Yeah, let me it's such an important question, and it's one, when we talk about the Medicare physician fee schedule, it's by definition a budget neutral space. And that was at the inception, which was late 80s, early 1990s was when that system was, in its current form, was developed. And policymakers at that time recognized that they couldn't have an infinite amount of spending on the Medicare program. So when you think about that, and the analogy is think of it just as a pie with many pieces of that pie, by definition, when one piece increases, the other pieces around that pie have to decrease. And let me give you a practical example where this sort of comes into play, and where, to Bruce's excellent question, where it may come into play in the future. So a few years ago, we reevaluated the evaluation into management CPT code. So those are codes for that image I showed of the physician with her patient. I mean, that's kind of your classic office-based visit. It's called an evaluation and management code. And we redid the coding structure to simplify it, and along the way, the evaluation was increased. The challenge with that code set is some of those codes are provided 100 million times a year. So once that was sort of put into the Medicare physician fee schedule blender, and those values were drafted, and the final budgetary implications concocted, there were some significant reductions to specialties that didn't provide a whole lot of E&M services, which frankly is radiology. We just, with the exception of IR and RO, most diagnostic radiologists don't do a lot of E&M coding. So that's an example of a concrete instance where an increase in one part of the pie led to a decrease in another. Now let's bring this to the context of this conference. Imagine a scenario where AI explodes, and we look at it critically and we decide this is something within the Medicare physician fee schedule that we need to pay for. Well, if that's the case and it's a budget neutral system, then by definition, reductions have to occur somewhere else. And it may be physician work, it may be practice expense, it may be neither, but these are the kinds of questions which we as thought leaders in this room and on this Zoom call need to ponder to inform, one, if it's worthy of an increase in payment, two, where that payment's going to originate, and three, what if any services may see reductions. And if you are going to reduce certain services, those providing that aren't going to like it, so how do you make that objective criteria to inform that? I answered your question with a question, Bruce, because I think it is just that, it's an open question.
Well, I'm hoping Richard will answer your question. Richard, do you have any comments on it?
No, I think Zeke's been pretty comprehensive.
Well, thank you very much. We do have a couple of questions from folks who are here. Please identify yourself.
David Yankelevitz from Mount Sinai in New York. You know, you asked who should be paid less. I was hoping your answer was going to be the actuaries, by the way.
What CPT code do actuaries build in?
I'm not sure. My question, I guess we're sort of touching on all of this. You know, I remember a person who had read a low-dose lung cancer screening and wound up being sued because they missed a breast cancer. You know, it's another organ, but the radiologist is responsible for everything. Now we're seeing an explosion of techniques for AI, for reading some areas that are already approved for screening, like osteoporosis, coronary artery disease, but more. And all of this, but there's no real way of getting reimbursed for these when they're reading those CT scans. And I suspect that, you know, more and more these are going to develop, and they're going to be really pushing the boundaries of what we can do for health. I'm wondering what you see the path forward in sort of getting reimbursement for these kinds of, I don't know what you call it, bonus findings or add-ons, whatever the right word is. But I really see, because right now, you know, I see many companies and they're struggling with getting codes, what to do. And I think this is going to become a big part of health in general.
Sure, I can take a stab at that. And I have to be careful because as a member of the CPT editorial panel, I would actually vote on code change applications that were presented, so please don't misunderstand anything I say as endorsing specific components of codes. I think that if you look carefully at the taxonomy, we're talking about something that simply points to something as distinct from something which actually quantifies that in a clinically meaningful way. So there's a transition there from simply detecting something that might be clinically relevant to actually determining the meaningfulness of that. And I think this helps to get at your question. Taking a step back, it's part of the reason we will probably need radiologists for a long, long time. You know, people say, I'm concerned that AI is going to take over from the radiologists. And, you know, my response is, AI won't replace the radiologist, but the radiologist who uses AI will replace the radiologist who doesn't. Right? And that's not being clever, that's being accurate. I think that the radiologist ultimately will be looking at the totality of the scan, not only for the reason that it was sent to screen for lung cancer, but for other things, whether it's a widening in the aorta or calcifications in the coronaries, or COPD, or bone mineral density loss, any number of other things. There's no reason that AI can't be trained to do the same thing. And so I can imagine a scenario in which the AI not only points to suspicious lesion that needs to be considered by the radiologist as potential lung cancer, but it could also say, oh, by the way, you might want to look at this, looks like a coronary calcification, or you might want to look at this area in the lobe, might be COPD, or you might look at this for bone mineral density. That is probably still a relatively low level, like CAD, raising those things to the awareness of the radiologist. The next step in the process could be that AI actually does the quantification, sort of like what the IDXDR product does for diabetic retinopathy. And if it actually not only quantifies that, but can interpret that relative to some known scale, then it might be a separate procedure being performed by that software. So I can imagine a future in which AI still, under the direction of a radiologist, not only detects things, but also quantifies them in clinically meaningful ways, and therefore would be directly useful in patient care. See?
No, I think Dr. Frick makes some excellent points. You know, one of the reasons my sort of dinosaur analogy was I hope relevant was, as we think about what we're going to do with AI relative to payment, and that is a hugely open question, but as we sort of ponder that at the most foundational level, understanding how we're currently paid for what we think of, you know, interpreting a CT or doing an intervention or a radiation treatment, depending on our specialty. By understanding how we're currently paid, we can evolve into a forward-thinking paradigm within the dinosaur that is fee-for-service. Now, the quality payment program, MIPS, you know, we can talk about APMs in a whole different light, but we're sort of still in this fee-for-service umbrella right now as far as our discussion is concerned. So if you go back to my slide and I said, here's how we determine work in the current paradigm. It's physician, it's stress, it's technical effort, it's judgment, and by the way, it's time. I mean, that's when we go to the RUC and someone, you know, fetal MRI, we took that code forward probably 5 years ago when I was an advisor, and we said, you know what, fetal MRI takes more time than a pelvic MRI because the fetus is moving. It's a stressful exam for the mother for understandable reasons, and the physician has to be there at the console directing that exam. So relatively, in that moment in time, we secured a higher relative value for fetal MRI for all of the right reasons. Now, take that pelvic MRI, because it's relativity, and imagine, let's do a chest CT just to kind of keep it within the context of this conference. Now imagine that chest CT, how it's currently valued, and now we have an algorithm coming on top of that and scanning for a pneumothorax, or a lung nodule in the setting of lung cancer screening, or emphysema quantification. What does that do to the physician work? I've heard arguments on both sides of this spectrum. I've heard arguments that have said, doc, that's considerably easier, the machine's doing the work for you, and it's less time, and you can do it with more confidence. So we're gonna value that less on this relativity scale. I've heard the other argument, which is, doc, that is more work because now you've got to not only look at your own organic interpretation, but you've got to look at what the machine is telling you is potentially there, decide if that's real or not. Oh, and by the way, you have to go out and explain to the patient that you used AI, and this is what algorithm means, this is what training data set means, this is precision, this is positive predictive value. I mean, all these conceptual terms that patients don't understand, so doc, it's more work. And then I've also heard the argument that, you know what, it's just like another sequence with an MRI. It's just additive to what we already have, and it's no difference whatsoever. So I'm really good at answering questions with questions, but the point being is there's a spectrum here that those of us who are thought leaders in this field are going to have to inform because that decision-making is taking place as we speak. Dr. Frank, do you agree with that assessment?
I want to give a somewhat different answer, which is that the value of the coding and the details of that goes far beyond reimbursement. That because administrative systems are ubiquitous and the data is easy and fast to get at, we can examine what we're getting from our healthcare system very quickly and accurately. For example, do we want to know if people who are in underserved areas have the same access to VAT surgery, or are they getting more open thoracotomies? That's something that we can quickly answer with administrative data because we have different CPT codes for that sort of thing. Do we want to know if people in underserved areas have the same access to AI assistance or I'm going to use the wrong term here, Richard. What's the term I want to use? Imaging that's autonomous. Mm-hmm. Autonomous imaging, not automated, autonomous imaging. Are there disparities in access to autonomous imaging? That's something that we can only really understand on a grand scale and quickly if we have distinct codes for that. So I think, the reimbursement aside, to understand what we're getting from our healthcare system in details without the pain of accessing charts, including electronic medical records, which are painful. Without doing that, we can get that quickly if we have appropriate coding. We have another question from...
I'm sorry, I want to build on his point real quick, because I think he's hit on something that is super relevant to lung cancer screening. And when we talk about CPT and we talk about it as a nomenclature, and again, Dr. Frank is on the panel, so he knows this as well as anyone, it's more than just payment. It's epidemiology, it's health policy research, it's assigning downstream value, determining outcomes. I mean, there's a whole list of functions that an accurate nomenclature entails. And I believe in that 100%. There's a dynamic we see in the real world, however, that when a code is not paid, we see instances where facilities and even doctors won't report that code. So there's this, and we saw in Anita many years ago, she and I worked on this together, looking at hospitals and their charges, and when they were doing certain services, including lung cancer screening, they weren't capturing all of the charges. They weren't necessarily capturing every pair of gloves or properly, I mean, you remember this, Anita, this was a really big effort on our part. And what happened was those payments incrementally went down. So having an accurate nomenclature is critical for all of the reasons, and having a fair and representative payment is equally, but perhaps in different ways, important. Dr. Frank, what do you think? Is that?
And I would just clarify one of Bruce's comments. Part of the reason there are 3 levels of autonomy is that people tend to think of autonomous as taking humans completely out of the loop. Well, the category 3 perhaps does in a way, but the categories 1 and 2 don't, and yet they still enhance, they still help to address underserved areas in the way that Bruce described. Yeah, that's a great point.
Terrific. And so just an example of underreporting, there are codes for medical errors that are rarely used, and I don't think, Zeke, you're suggesting we should pay for those codes, but perhaps there's other ways to encourage better coding. It's certainly important. Our next question.
Yeah, Jim Melshine. Thank you very much. This has been an incredibly informative panel, and you very carefully and thoughtfully went through lots and lots of issues. But frankly, it's terrifying because if you think about, the logical evolution of this, the precedent for this is Epic. Epic is a system that was designed to do some of this stuff in the context of care. So the end result, I think, is that we got the billing portion exquisitely attended to, and the care kind of got left out in the rain. And the reason why I say this is because, we're talking about, this transitioning from the dinosaur to whatever. And, when we think about prevention in the setting of really exquisite early detection associated with molecular diagnostics or imaging diagnostics or whatever, we're going to find, pre-symptomatic states very, very early in which, the intervention of choice is going to be physical activity or stress reduction or better nutrition or better sleep hygiene or whatever the devil it is. And we don't have any of those people in the current lexicon. And so the issue becomes, how do you get a system where the exercise physiologist who gets prescribed is going to be doing exercise for lung cancer or COPD, but it turns out it's also going to help the bone structure. And what piece of that do you ascribe to whatever? And it gets so complicated. We need AI, frankly, for the billing, but we need AI in the cloud, so it's back office, so the focus can still be on the interaction of care. And it's just so complicated. And I was thinking, Richard, during your excellent presentation, it's all one-offs. And so you can have a solo instrument playing, and we can have a CPT code and all this other stuff, but we live in a world of symphonies in which there's all this choreographed interaction of all these different elements. How do we do that? And not, spend a millennium getting there. So we got to kind of find higher organization levels and tools to deal with macro kind of things.
Before Richard answers that, I invite you to ask that question to this afternoon's panel, because I think that's a population health issue. Richard, go ahead.
Yeah. Well, and I would agree the question is more appropriate for this afternoon's session, but I'll answer it only in part. And that is trying to stay within the guardrails of the code set, right? What we've done in creating Appendix S is provide descriptors that can be used for this discrete and differentiable creation of codes for the specific task which is being done. And this is an enabling function. It doesn't answer the higher level questions about how we should be paying for Medicare and so on. Yeah.
But I agree, it's 100%. So when you think about it sort of from a regulatory perspective, change in recent years, creation of Medicare was huge, and the biggest change was probably the Affordable Care Act. But in 2015, when the Medicare Access Chip Reauthorization Act passed, that was kind of the one where everyone said, all right, the dinosaurs are dead. Fee-for-service is going out the door. And I acknowledge every limitation you just described regarding fee-for-service's ability to enable innovation. That's the criticism the system receives. My argument to that has been, there's no alternative payment model that doesn't have some basis in the ability to report, as Bruce nicely described, or per unit payment potentially. But the uptake of the programs put into place by MACRA in 2015 has been dismally slow at best. APM update is low. Accountable care organizations, which actually are from the Affordable Care Act, have been slow, especially the risk-bearing models. MIPS is even really clunky. So you ask yourself, are we able to do it within a federal system? We certainly play in the federal system. We certainly spend time in that sandbox. But I think we're informed by that, but I think it's going to be the innovative centers, innovative institutions, innovative states, and innovative meetings of this sort that are going to do exactly what you said, and that is to do what would seem to be simple on paper, but in practice becomes unwieldily complex at times. Thank you.
Paul Pinsky, NCI. Sort of a question and a comment about barriers to AI implementation. So we have a image library of low-dose CT from the National Lung Screening Trial, which is basically anyone can easily get access to the data and the corresponding images. So in about 10 years, we've had literally 500 applications for the images, a lot from the private sector as well as academia. And I'm wondering, I don't track it, but it doesn't seem like many or any of them have actually gone to any use, any clinical use, or at least widespread. So I'm wondering if it's more like a technical AI is the main barrier, they haven't gotten good enough models, or more like a regulatory and business that, you know, the expense of going through the regulatory and then how much money they could get, you know, in the business case is more of a barrier than technical AI.
Well, this is a complicated question. I mean, there's a multi-step process leading to patients gaining the benefit of innovation in AI. And you've listed off a couple of different waypoints along the way. And you can be sure that venture capitalists and little garage band startup companies around are all trying to figure this out. And they tend to, I mean, if I put this in a venture capital perspective, they generally will have an exit strategy which is intended to maximize the value of their investment while achieving that by reducing risk and the likelihood that becomes a product. And they tend to think historically only of FDA clearance. Well, now they have to think of a lot more than that downstream. It's not just clinical integration and workflow. It has to do with coding, coverage, and payment, and so on. So you're right to raise this as a complicated question with multiple steps along the way. And the implications, the reason it's important to recognize that from the beginning, and the reason I put it in a venture capital standpoint, is they might see getting FDA labeling as their exit strategy, and they don't much care what's in the label so long as they get the product into the market. But what the wording that's in the labeling may have implications for coding and ultimately coverage. So you do need to think of it as you've described in its totality. Yeah.
I think it's worth asking the question, so when these algorithms are rolled out in a clinical practice, you know, what are they technically approved for? I mean, in general, it's triage, detection as opposed to true diagnosis or downstream informing healthcare outcomes. And so as that transition potentially evolves, I mean, it comes down to transparency, safety, reliability, I mean, efficacy. I mean, these are the questions that I hear the docs on the ground asking when they find these products as part of their toolbox. I'm good at asking questions to questions, and it's a very open question.
I might have a somewhat different answer. I don't disagree with the panelists' response, but if you look at where investment goes in healthcare, there are huge opportunities to have gains in things that are easier. So you can buy a drug company that collects off-patent generic drugs with very few manufacturers and raise their prices. You can buy physician practices, pay the physicians less, hire a lot of NPs and PAs, and have a bigger churn of patients going through. And you see this in the escalating spending as a portion of GDP on U.S. healthcare. So, as I like to say, you know, the big sources of profit in the past might have been things like arms deals internationally, or you know, real estate speculation, or things of that sort. Today, it's healthcare, and the struggle we have is the very technical and sound scientific developments that we discuss at meetings like this are hard, and there's capital tends to get attracted into things that are easier. So until we, from my perspective, I think having constraints on healthcare spending and even an expectation of deflation would be good for the true innovators, because it would make them look more attractive relative to the other sources, other ways that money flows in the system. So I don't disagree with either Zeke or Richard on what they said, but I think from the standpoint of where money goes, and we're in a challenging place in healthcare. I think we're at the end of our time, so I'm standing between folks here and lunch, and we're going to reconvene at, correct me if I'm wrong, 1:15. I'd like to welcome you to the first afternoon session of the program, the Quantitative Imaging Workshop 19. And this is a continuation of this morning's discussion on population health and reimbursement. And this morning this is Bruce Pineson. I'm a principal and consulting actuary at Milliman, and just finished 6 years on the Medicare Payment Advisory Commission as a commissioner. And with me is Anita McLaughlin. If you could introduce yourself, Anita.
Anita McLaughlin, I'm Senior Director at Go-To Foundation for Lung Cancer, speaking into the microphone. And I am work closely on health policy and economics issues. I'll be working behind the scenes today and answering questions online that come in through the chat session.
Thank you, Anita. We have a number of sessions, a number of speakers this afternoon in the next hour, so we're going to go quickly through them. I have some introductory remarks to set a context there, and let's see. Let me tell you first who the speakers are going to be. We have Brandon Conroy, who's Vice President of Underwriting and Actuarial at Magellan Health, which manages radiology benefits for millions and millions of people. We've Deborah Dyer, who's the Chair of Radiology at National Jewish Health. We have Lee Gazorian, who's also in the room with us, who is the Director of the Lung Health Program at Leahy. And if you were here this morning, you heard about the Bradys and the role they've had in lung screening, and they're from Leahy as well. Lori Gianturco, United Healthcare. She's the National Medical Director for Radiology for United Healthcare, which covers tens of millions of Americans. She also, before joining United, was running a lung screening program in Massachusetts. And Ginny Prater, who is Medical Director at Blue Cross Blue Shield of Alabama, and is a geriatrician and expert in bone density. To start, I want to give some background in the context for radiology benefit management on the grand scale that we have. And as we discussed this morning, reimbursement and payment is important, but the context for payment and population health is not pretty, especially in the United States. I've used the thesis that the more we spend on healthcare, the worse our health outcomes are. And that's counterintuitive, perhaps, to many in the room, but the rationale is that the more we spend on healthcare, the less we have to spend on things that are actually more important to health than healthcare. Things like wages and education, things like housing, infrastructure, environment, and equities. And I want to remind folks of that because the role of radiology benefit managers and management of healthcare in general is controversial, especially to people in hospitals and people in research roles. The need to manage spending of healthcare and manage the resources is critical. And advocates all advocates have always asked for more funds for the concerns they're advocating, but hopefully we'll create a context for that in the next few minutes. This is a chart from the September meeting of MedPAC that shows the share of gross domestic product in the United States that's going to healthcare. The lines on the bottom are Medicare and Medicaid and private spending, and we're close to 20% in total spending. And by the way, most of the difference between the lines on the bottom and the total is out-of-pocket spending that is not covered by insurance. So you add up the pieces on the bottom, it's roughly 13%, and there's a big gap between that and the close to 20% total. So the out-of-pocket spending people have is significant. And whether the spending is out-of-pocket or from insurance, it's still a deduction from funds that could go elsewhere. Ironically, in the United States, the spending by the public, by the government, is similar to the spending of other countries. Even though the United States spends way more on healthcare than other countries, the spending by our government is about the same as spending by other governments. The difference is the out-of-pocket spending. This is a slide from the Commonwealth Fund, and you can see in the U.S. the green bar, the and the orange bar are very significant. So we have private spending paying a lot more than we see in other countries, but the government spending is similar. The U.S. does have a lower life expectancy. You can barely see it in this slide, but the numbers are in the chart on the right, where U.S. life expectancy of about a little over 78 years, and the other countries shown are all in the low 80s. And the rate of avoidable deaths is higher in the U.S. off to the right. In 2016, 112 avoidable deaths per 100,000, compared to numbers that are in the 50s to 80s for other countries. So the bottom line is we're spending a lot more than other countries, and our health status is worse. And that's a story that's repeated over and over again in lots of other statistics. I just took a handful of statistics here. So the discussion that we're going to have this afternoon is a description of how the folks that manage radiology benefits do their business, and we're going to have questions for them on what that means for lung screening and thoracic screening. So we have some pre-recorded presentations. Our goal here for the Prevent Cancer Foundation and the audience is to get a better understanding of how millions and tens of millions of people access the radiology benefit, because as we go from lung screening of a few 100,000 people a year to millions of people a year, it's going to have to move out of the centers that are doing it now to the ambulatory centers and the communities. So with that, could we run the presentations?
Brandon Conroy, the VP of Underwriting and Actuarial for Magellan Healthcare. We are a benefit management company that is a vendor that health plans carve out to manage some of their benefits, advanced imaging being one of them, and I'm going to talk about advancing imaging management today with you. We manage about 25 million lives at Magellan on the RBM, under the RBM benefit. So I'm going to talk about some of the goals and challenges of managing advanced imaging. The goal basically is to reduce unnecessary utilization and promote the most effective study with the least amount of exposure to radiation. Some of the challenges are overuse. A majority of surveyed physicians, about 60%, indicated physicians being unfamiliar with appropriate diagnostic tests. And that's contributed to a lot of the unnecessary imaging that takes place. And that's where someone like Magellan can come in and help with that. A lot of the overuse and unnecessary imaging is due to defensive medicine, and that up to $30 billion is spent annually on unnecessary images. Part of that is due to patient demand. 65% of physician leaders say that patient demand is a significant factor in unnecessary imaging. And that's where you obviously have your patients trying to cover all the bases and really not needing that imaging being done, but physicians oblige and a lot of unnecessary imaging takes place. And of course, the health of the patient is a very high important factor. So a lot of these images have higher exposure to radiation and higher risk of cancer because of the imaging. So we want to keep that low and the patient healthy at all times. I have a couple case studies just to discuss when we think about managing these advanced imaging benefits. On the left-hand side is a case study on the brain study using MRs versus CTs. So this is basically just for the health of the member. But as you can see, that first data point on the graph shows that depending on what age group you're looking at, all members of the green line there, it's between 60 and 70% are using MRs versus the CTs. And once we implement management, you can see that immediately jumps up to 80% for all ages. And it even eventually, after 4 or 5 years in the program, it even gets up to 85 to 90% using MRs, which are the safer, healthier type of imaging. On the right-hand side, this is an example of the combined thoracic CT. And what that is with and without contrast. And as you can see, the example shown under pre-management, 28% of studies are under that combined thoracic CT. Immediately after management gets in place, 11% occurs. And then after a year or two, it's down to 2%, which is the block of business kind of benchmark or threshold that we go after. I think 2% is the clinical measure that we want to aim for. And at 28%, that was just very, very high compared to the benchmark. Here we have some examples of clinical outreach we have to the providers themselves. This is based on a New York health plan. And this is an example, real life example at Magellan. Some of the things that needed to be addressed, they had a higher denial rate, this particular provider. So that's a clinical denial rate. And what we did was go over the guidelines. We trained them on the guidelines. We talked to them about the process and reinforcing the idea of using the website, which is important as well. That just expedites things. And some procedures get automatically approved over an algorithm. So as you can see, the targeted provider pre-outreach, so Q2 of 2021, their clinical denial rate is 32%. And post-outreach in Q1 22, it's 21%. So that's just a lot of savings on the health plan side, a lot of administrative savings when you're talking about how much it costs us to look at these claims, review the claims, and deny them if needed. And here's kind of where my bread and butter is, being a health actuary, just talking about the financials of the plan. So this is a advanced cardiac imaging program management. And this is an example, but to give you an idea of the dollars involved and how we present these to the health plan and health plan management to decide if they want to have an outside vendor manage their plan for them. So this health plan in particular is about 150,000 members, so not a very large plan. I would say a mid-sized plan. Utilization per thousand is 154 utilizing members per 1,000 members. The paid per utilization, which is basically the average cost of each utilization, is $1,516. So that PMPM, that translates to a $19.44 PMPM. To give you an idea, the total spend for a commercial group is around $500 PMPM. So that gives you an idea of how much the RBM benefit is compared to the total spend. And then the managed paid PMPM, so after our management is in place, we expect it to be $16.14 PMPM. So going from there down to the bottom, you see total dollars spent. So of that 1944, that's $35 million. So again, not small potatoes. I mean, that's a lot of money for this 150,000 member commercial plan. We feel like we can manage that down to $29 million. So as you can see, the gross save there is $6 million. The admin fee going back up is the ASO fee is 50 cents for us to do that. Basically just under $1 million. And so the net save would be about $5 million. So that's ROI for that is 6.6 to 1, which is a very attractive ROI on the spend, how much the plan would spend to manage us to get down $5 million basically. So that's my presentation. Thank you for your time.
Hello, it's a pleasure to be with you today. I am Debbie Dyer, a radiologist at National Jewish Health in Denver, Colorado. And I also serve on the American College of Radiology Lung Cancer Screening 2.0 Steering Committee. I'm delighted to talk to you today about how we can advance the uptake of lung cancer screening and particularly address the role of payers and radiology benefit managers. So what can payers and radiology benefit managers do to improve the uptake of lung cancer screening? First, they can make it easier for patients to get screened. As many of you may know, the eligibility criteria for lung cancer screening are complex, and there are a number of qualifications that patients need to meet to be able to get screened. As long as patients meet these qualifications, then they should be able to get screened. And in that way, we would like to see that payers and RBMs would eliminate the pre-authorization requirement, because if patients really do meet those criteria, then they should be eligible. But obviously, it's also important for payers and RBMs to be up to date on the eligibility criteria for lung cancer screening. And fortunately, in the past couple years, those eligibility criteria have changed and they've improved, and it's made more people eligible for screening. So as you know, the starting age has dropped to age 50. The number of PAC years required has dropped to 20. Certainly we still have in place that patients need to be currently smoking or have quit within the past 15 years. And of course, patients cannot have any signs or symptoms of lung cancer. But Most of the navigators and schedulers involved in lung cancer screening are very aware of these criteria, and many patients go through a shared decision-making visit, particularly those patients that are on Medicare. So providers in essence, do know who to refer for lung cancer screening. But certainly we want payers and radiology benefit managers to be engaged and ask questions. And certainly radiologists and other folks that run lung cancer screening programs can be very good resources. Now, what can the radiology profession do to assist? Well, one of the things is certainly we can help educate navigators and utilization managers and the pre-auth team at imaging facilities or hospitals about the eligibility criteria and making sure that they know the updated criteria. We can educate and be a resource for healthcare providers, particularly primary care providers. And we know that the primary care providers have a lot on their plate. So the easier we can make it for them to refer a patient to lung cancer screening, the better. And some lung cancer screening programs are centralized so that the primary care providers, all they have to do is send a referral to the lung cancer screening program. And then the lung cancer screening program can take it from there, confirm eligibility, order the CT, get the CT done, and help manage the results. Now, another thing that radiologists can do is talk to patients. And in fact, if the radiologist is able and has the opportunity to review CT findings with patients, that can be just incredibly powerful. Images tell a big part of the story. There may not be a lung nodule that's suspicious, but there may be other evidence of smoking-related disease on the CT, and this can be a teachable moment for smoking cessation if the patient is still smoking. Another thing radiologists can do is become involved in their state cancer coalitions and work with colleagues to really improve the uptake of lung cancer screening and work around the state with other folks that are like-minded and encourage that lung cancer screening programs be started, or that referring providers know where to send patients for lung cancer screening. The other thing that radiologists can do is speak to community groups or business organizations and participate in health fairs. Again, engage with the community and let them know about lung cancer screening. Also, it's an opportunity to tell them about what radiologists do and how we can help improve population health. And then I wanted to just spend the last couple moments here telling you about a very exciting event that is coming up on November 12th, and it is the first ever National Lung Cancer Screening Day, with the tagline, "The next life we save may be yours." These marketing materials are available through the American College of Radiology, and you can see other sponsoring organizations, including the American Cancer Society, the GO2 Foundation, the National Lung Cancer Roundtable, and the Radiology Health Equity Coalition. All these groups have come together to help sponsor this nationwide day where we're inviting patients to come in for screening. If they can't come during the regular work week, then we're offering a time for them to come in on Saturdays. These materials can be customized to individual sites. So I thank you. I thank you for the opportunity to share this information with you, and I look forward to the panel discussion. Thank you.
Hi, it's a real pleasure to be here today. My name is Lee Kazorin. I'm a pulmonary critical care physician at Leahy Hospital and Medical Center, and I'm going to talk a little bit about our lung health program that we're just starting up now. First, I'd like to say that, without the McKees, Brady, and Andrea, the foundation for what we've put in place would never have happened. The work that they did is basically giving us a roadmap on how to replicate lung health similar to our lung cancer screening program. So first, I'm just going to give you 2 examples of the problem. These are real patient scans. The first is a 77-year-old male who had a stage 1B squamous cell removed in 2018. Subsequently, he's been followed annual by CT surgery. His pre-op PFT showed an FVC of 75% predicted, and there on the left is his CT scan from 2018, the preoperative one. And the scan does demonstrate a probable UIP pattern in the lower lungs. Fast forward to April of 2022, and his CT scan now shows a typical UIP pattern, yet he has yet to have PFTs, he's yet to been referred to pulmonary. He's being managed for his lung cancer, which is cured, but I'm afraid he's developing progressive UIP. And so this is one of the first patients who's going to be receiving a letter from our group to come to our clinic for evaluation. Second example is a 35-year-old woman with a 0.5 PAC year since she was 16 years old. No past medical history. In January of 2016, she presented to the emergency room for chest pain. She had a CTPA that was negative, was discharged. As of January of 2020, she was still smoking. There was no documentation of emphysema in her medical records. And if you look at the CT scan report from that time, the clinical read showed early bolus emphysema. And you can see there in the anterior lung field that there's significant emphysema. And this is what we're trying to avoid. Can we catch these patients at 35 and prevent them from showing up at 50 with advanced disease? So the lung health program, the model that we're developing is based on developing centers of excellence for interstitial lung disease, emphysema, COPD, and bronchoscopic lung volume reduction screening. There's cardiac risk assessment. There's an incidental nodule program that's actually up and running that's being led by Dr. Carla Lamb. And what this does for Leahy, this increases value to the hospital where we have centers of excellence under these specific diseases. It allows for growth within our Department of Pulmonary and Critical Care. And then because of the background in the lung cancer screening program that the McKees helped start, there's an amazing opportunity for research within our population. So, but more importantly, how do you get a lung health program up and running and get it to be supported by the hospital? You have to show program growth and you have to show the return on investment. If you can save a lot of lives, but the hospital's going to lose money, you're not going to get support from a program. So for us, we started with emphysema and interstitial lung disease. Our projections are that it's going to increase pulmonary volume to our clinic, increase PFT lab volume, increase referral for bronchoscopic lung volume reduction, and in conjunction, patients who don't qualify for BLVR may be surgical lung volume candidates. And then there's other potential for coronary calcium and incidental nodules in addition. But we're currently starting with emphysema and interstitial lung disease. So our model, I'm going to talk a little bit more about this in a later slide, but it's a central navigator-based system. Radiology is providing us the clinical outputs. Right now for interstitial lung disease, we're using natural language processing to review all our CT scans. In addition, for bronchoscopic lung volume reduction, we're using Enbio's LDA algorithm. So that data is coming to our central navigator, and right now you're looking at the navigator. It's amazing. We're building a program with 2 pulmonary critical care physicians who are intensivists and building an outpatient program. What could go wrong? So we're with the central navigators. We're outreaching to our primary care docs, getting approval for the referral to our clinic. And then once they sign off on the referral order, the patients get a letter. We're developing a novel pathway where radiology will be sending patients a dedicated quantitative image of their lungs with their pathology to increase patient engagement that I'll talk about later. And then finally, the major objective of our program is to reduce fractionated care. So we want to be able to identify the high-risk patients, get them to the specialists who can improve their overall health care. And then finally, this is all supported by Three Legs Foundation. So this lung health clinic wouldn't have started without a grant from Three Legs Foundation, specifically for interstitial lung abnormalities. But Three Legs sees the larger vision of lung health and other diseases, such as coronary calcium, emphysema, bone density. And so Three Lakes is working closely with CHEST for interstitial lung disease for early symptom recognition, educating PCPs to get patients improving time to diagnosis. And they're backing Leahy's model of leveraging existing scans. So right now, we're not just using lung cancer screening scans, we're using all scans performed within our institution, including abdominal scans for screening for interstitial lung disease. And our model is to engage the PCPs, get referral to the specialists, and the eventual goal for all of this is early disease recognition, whether it's interstitial lung disease, emphysema, coronary calcium, or lung nodules, and getting patients to the specialists. Thank you.
Good afternoon. I'm Jenny Prater, and I'm one of the medical directors at Blue Cross and Blue Shield of Alabama. I appreciate the opportunity to speak to you today about the value of prior authorization. Some of you have probably seen this graphic depiction of how United States healthcare compares with that of other OECD nations. On the x-axis, you see annual per capita health expenditure, and life expectancy is on the y-axis. Each point represents this data over 1 year between 1970 and 2013. You can see that the U.S. seemed to be trending with other countries until the mid-1980s. And since that time, our spending has increased out of proportion with gains in life expectancy in comparison with other countries. So what are the drivers of our poor performance? First, health is not all about the delivery of health care. It's estimated that only about 20% of health can be accounted for by medical care. The other 80% of health broadly is influenced by genetics, behavior, the environment, and social determinants. There's been a recent push to understand more about social determinants of health and to move toward interventions that address them. Another driver is that low-value care is prevalent. It's been estimated that around $75 to $100 billion annually is wasted within the U.S. healthcare system. Not only are these dollars being wasted, but they're being spent on care that's associated with harmful patient outcomes and further unnecessary testing. The Dartmouth Atlas Project, which uses Medicare and Medicaid data for analysis, suggests that up to 30% of current healthcare spending is wasted. Instead of delivering low-value care, we want to support high-value care. There are many definitions of high-value care. The American College of Physicians defines high-value care as health care that improves health, avoids harm, and eliminates wasteful practices. Physicians understand high-value care as care that balances benefits with costs and harms. Choosing Wisely is an initiative of the ABIM Foundation, which is now celebrating its 10th year. Multiple specialty societies have participated in creating recommendations based on high-level evidence. There's content available for clinicians and for patients. One example of an evidence-based recommendation for clinicians comes from the Society of Hospital Medicine, advising not to order daily chest x-rays in hospitalized patients unless there are specific indications. An example of content created for patients comes from the American Chiropractic Association. This content includes easily understood information explaining the following: which tests and treatments can help, that most people with lower back pain don't need imaging tests, when imaging tests might help, for instance, when there's a fracture, osteoporosis, or cancer, advice to avoid passive therapies unless they are given along with other treatments, and advice to avoid regular use of lumbar supports or braces. Prior authorization seeks to support the delivery of high-value care. It ensures that a requested service or procedure is appropriate, and that it is delivered in the appropriate setting at the appropriate time. Prior authorization is based on high quality evidence. The policies and guidelines used for prior authorization are created by physicians with subject matter expertise. They are also open for feedback from network providers. Prior authorization can result in less duplicative or unnecessary care, less risk for treatment interactions, and less exposure risks for patients. And finally, prior authorization seeks to ensure that members do not receive surprise bills for medically unnecessary services. Prior authorization for advanced imaging has resulted in avoidance of unnecessary ionizing radiation exposure. This is the experience of Blue Cross and Blue Shield of Alabama. To give you an idea of scale, we serve approximately 3 million lives. In 1 year, over 10,000 unnecessary CT scans were avoided, resulting in avoidance of up to 17.66 millisieverts per patient. In 1 year, around 2,000 unnecessary PET scans were avoided, resulting in avoidance of up to 51.67 millisieverts per patient. Of the CT scans that were impacted by our prior authorization process in 1 year, 36% turned out to be duplicates. In our experience in 1 year, prior authorization resulted in redirection to a more appropriate evidence-based approach in up to 76% of cases for genetic testing, in up to 10% of cases for advanced imaging, and in up to 5% of cases for oncology. Thanks for your attention and your time.
Good day. My name is Dr. Lori Gianturco. I am the National Medical Director for Radiology at United Healthcare. My background includes over 20 years of clinical practice and administrative experience in healthcare. I have an expertise in nuclear medicine and body imaging, and was the consulting radiologist to a thoracic oncology team in our healthcare system in Massachusetts for over 10 years. I also have the sad experience of the loss of a close family member to lung cancer prior to the development of screening CT programs, so this topic is very close to my heart. Thank you for the opportunity to speak at the Quantitative Imaging Workshop to continue the development of lung cancer screening programs to improve early detection and reduce mortality. So today I'm going to talk very briefly around standard health plan activities, specifically radiology benefit managers or RBMs, network management, and quality management. Most health plans have a radiology benefit manager to manage appropriate utilization of advanced imaging. Medical policies are developed by a specialized team and updated once or twice a year based on the most recent research, medical literature, and professional society guidelines. For Medicare, national coverage determinations and local coverage determinations also determine whether certain services are covered by Medicare. The medical policy guidelines are typically posted on the payer's provider website. These benefit management programs require that the ordering or rendering provider with knowledge of the patient submit clinical information for a pre-service review of the elective imaging service. This is known as the prior authorization review. This is done typically only for elective procedures and not for inpatient or emergent procedures. An example of this would be the use of MRI for low back pain, where the guidelines might require that the patient meet certain clinical conditions in order to get an approval for this procedure. If allowed by law, RBMs also offer a peer-to-peer discussion where clinical information submitted does not meet guidelines in order to have a clinical discussion about the procedure. RBMs and all prior authorization services are heavily regulated and monitored by health plan accrediting bodies, the health plan itself, and NCQA and URAC, as well as state and federal agencies. Separately, and in addition, individual states may pass bills and issue mandates that require insurance cover of certain services. A typical example of this would be states mandating coverage for 3D mammograms. Network management. Health plans are required to contract and to maintain a network of participating providers for many services. As part of a network arrangement, there may be requirements for quality and safety for credentialing of individual providers and/or accreditation to make sure that the providers and the facilities meet quality and safety standards. For example, health plans might require that radiology providers who provide certain modality services maintain accreditation from the American College of Radiology, RadSite, or one of the other accrediting agencies. Quality management. So Medicare and health plan accrediting bodies require that health plans measure and report on their quality performance and member experience measures and the plan for improvement. This impacts their publicly reporting ratings, which typically range from 1 being the lowest to 5 being the highest. Medicare uses what's called star ratings. Consumers then can use these ratings to compare and select their health plan. NCQA, an accrediting body, one of the larger accrediting body, uses HEDIS measures, and that stands for Healthcare Effectiveness Data and Information Set across 6 categories of clinical care that include the effectiveness of care, the access and availability of care, the consumer or member experience of care, and utilization. Some examples of effectiveness of care measurements would include prevention and screening. Currently, lung cancer screening is not a measure in the HEDIS measure set. However, breast cancer and colon cancer screening are. Another example would be osteoporosis testing and management in older women. And effectiveness of care can also include overuse or appropriateness, such as use of imaging studies for low back pain. As part of accreditation, there is a required annual survey called CAPS. That's the Consumer Assessment of Healthcare Providers and Systems. It's developed by the AHRQ, the Agency for Healthcare Research and Quality, which asks members about both their health plan experience and their experience with the healthcare system. Health plans have a quality division that tracks the survey and quality measure results and creates programs and plans to improve their results and their ratings. An example of this would be to increase the screening rates in women for a screening mammogram of the appropriate age. Another would be to improve the survey results from their members who have current tobacco use about smoking cessation counseling. In summary, health plans maintain tools and programs for access, utilization, equity, quality, and safety of care for their enrolled members. These tools are audited and regulated and are a major source of their quality ratings, which are publicly reported. From a health plan perspective, I'd like to just say what the desired state for screening programs would be as the roadmap for lung cancer screening continues. There would be the need to really have comprehensive screening available at a population level, a high quality, accessible network of providers across the country who can perform these procedures. And health plans are always concerned that these networks are available not just in urban areas, but in rural areas and to all their members. High quality studies for low dose chest CT, standardized reporting, a comprehensive screening program, member outreach and education, smoking cessation counseling, shared decision making, and follow-up of both normal and abnormal results to make sure that the screening leads to the intended outcome, which is to improve early detection and treatment for lung cancer. Thank you very much.
Well, I want to thank our panelists for their presentations, and we had a variety of organizations represented. I'd like to invite the panelists who can connect to turn on their cameras and because we've got some questions, and like to get your feedback. And one of the things I want to start with is the size of your organization. Brandon, I know you had said that Magellan serves, I think, 20 million lives, and Lee, I'd ask you the same question. You know, the program that the McKees established have certain patients, but overall Leahy, how many lives does Leahy serve?
You know, I can't give you the exact answer on how many lives, but I can say, you know, we perform close to 40,000 CT scans a year. Those are chest and abdomen combined. So there's a large opportunity to capture incidental disease within our population.
But if you were I think you're an accountable care organization.
We are. I just don't know the numbers. I know we're number 2 in the state. The Partners has the largest capture, and the BI Leahy Health Network is the second largest health system within Massachusetts.
Oh, okay. Well, thank you. And Ginny, how many lives does Blue Cross Blue Shield of Alabama insure? I'm sorry. I think you might be on mute.
It's approximately 3 million.
$3 million?
Yeah.
I'm sorry, I couldn't hear. So we have a range. United Healthcare, it's probably safe to say, is bigger than everybody because they're the biggest insurer in the country. Deborah, National Jewish, do you have a sense of how many people you serve?
So National Jewish is a referral center. Geez, why is that happening? It's a referral center for chronic lung disease, and we get a lot of patients from out of state as well as in state. But we do about 20,000 chest CTs a year.
There's a big, small organizations, large organizations represented. We're going to hear tomorrow from some of the speakers from Rickavilla, the idea that imaging, the machine or the system, it's not just important for that device to report with accuracy, but it's important to capture what the findings were of the previous scan, and have that consolidated, reported together, as Jim Mulshine mentioned this morning. The process of screening is not a one-time process, but requires comparisons with the prior year and the next year's scan. Whose responsibility is that? The payer organizations know that people move around, and if I get screened, even if my insurance doesn't change, maybe I go to the Atlantic healthcare system in New Jersey this year, and next year I'll go to Summit Health. Whose responsibility is that? Let me rephrase that. Is that something that the payers or the radiology benefit managers can take on as a responsibility? Continuity of reporting and comparison from the prior scan to the current scan.
Well, I can offer in my setting that it is not the responsibility of the payer. It does become the responsibility of the institution. And as a radiologist, I feel responsible to have that comparison scan. And one of the real disadvantages of our fragmented network of healthcare is that patients do go to a variety of places to get their imaging. And that does kind of bring up one thing that I just wanted to be able to toss out to this group is I am really troubled that there is a move towards patients being redirected from hospital-based imaging to off-campus, off-site imaging centers. And just as an example, the largest payer that you just mentioned has sent out a notice just this past week that starting February 1st, lung cancer screening, in fact, any screening, is not going to be allowed at hospital-based facilities. And I was...
Hospital outpatient.
No,
Relative to the community.
hospital outpatient-based facilities. So that was really pretty horrifying because, and it also talked about that the workup of an abnormality also would have to be done elsewhere, and monitoring the surveillance post-treatment would have to be done elsewhere. So that removes the patient from really a lot of the oncology imaging continuum and would just contribute more to the fragmentation of managing patients. And this is just particularly troubling because, in fact, we just heard about the importance of having a comprehensive screening program. And there are some very good programs that are outside of hospital systems. But I just want this group to know that there are a lot of the successful, established, organized, comprehensive lung cancer screening programs are hospital-based. And if we have these...
If I could interrupt because the clock is ticking. I'd like wonder if our other panelists could comment on that, Brandon or Ginny or Lee. You know the. Go ahead.
I have an opinion of whose responsibility it is to ensure continuity. Can you hear me? There might be a little echo. So when I see patients in the osteoporosis clinic, I take it on myself as the provider to make sure that they understand they need to have their DEXA scans done on the same scanner or at the same site where the scanners have been cross-calibrated. Otherwise, we won't be able to tell them about the interval change in their bone density. So I think similarly, the provider shares some responsibility in educating the patient about not switching if possible.
So is that, Brandon, I wonder if you have thoughts on that, and in particular, if Magellan would be interested in that consistency of information.
Right. I can say is from the imaging standpoint, I understand what you're saying about the whole continuum. We are going to. We normally don't do like a facility site selection for RBM where we try to steer coverage to an outpatient setting. So we really don't necessarily, consider that as part of the denials or shifting or anything like that. At times, I think it makes sense if it's maybe not necessarily for this medical service, but at times it makes sense for certain things. But for the lung cancer screenings, it's not necessarily part of our practice or program to do that.
Good to hear.
Lee, your thoughts?
I think the fractionated care that Dr. Dyer was talking about is one of the major problems. If these scans are being done at outside communities where, the tertiary centers can't actually even see the images, that's a major problem. And I think that brings up a bigger issue is we need to have the ability to review scans that are done anywhere. So there's some questions in the audience, I think.
working. Javier Zulueta from Mount Sinai in New York. Lee, this is a question to you. And as we are setting up also incidental finding tracking programs, there are many potential obstacles and complexities that we're adding to healthcare instead of, like for instance, you and I are both pulmonologists, and as you start reviewing reports from another specialty, and eventually you might even run a software that's going to detect nodules that were not reported on initially. On the other extreme, you have primary care physicians who might feel threatened or have the feeling that you're moving into their territory. And then a third potential obstacle is liability. So anyway, if you can please comment on these for our education.
The first one is the outreach to the primary care. I think this is one of the critical things for a successful lung health program, and this is what the McKees and our lung cancer screening program showed. We had the buy-in from our primary care physicians. So when lung cancer screening started at Leahy, the primary cares were the ones who referred. And so that was one of the big parts of the success of the program. And then we've tried to replicate that with our lung health program. We've had lots of meetings with our primary care group, let them know that this program was rolling out, and they've been 100% supportive. Picking up additional findings is going to be a problem. And getting the workflow going, it's really difficult in the sense that we're having trouble just getting Epic to write the order for us so that we can actually get patients referred to our clinic. So there's a lot of hurdles, but I think we can overcome them with effort.
Question for the audience?
Yeah, Jim Melshine, Washington University. Excellent panel, important issues. Really enjoyed the part about quality control and the question about eliminating variability so that, reading across time could be more standardized in different settings and whatnot. And to that question, Brandon, with 25 million covered lives, I don't see anything evaluating the quality of the image and the imaging data fidelity in any of these discussions. And we're going to hear tomorrow from Rick and others that there are possibilities now of web-based, cloud-based evaluation, almost real time, of image quality, such that a system could become very aware of the fact that their acquisition parameters or whatever are not optimized. And these could be corrected at virtually no cost and eliminate the misguided resources consequent to having an inappropriately acquired image as a grist for decision-making, clinical decision-making. Preliminary research around this suggests that up to 50%, 60% of current images across the world are obtained maybe at a level that's fine for visual interpretation by a radiologist, but are totally suboptimal for quantitative assessment. So is there a willingness of your organization, of others, to start moving to, at least experimentally, into some of these auditing of the image acquisitions to try to bring these up so that more comprehensive analysis of these acquired images can be done reliably?
I think that was a question probably directed at both Brandon and Ginny. But
I can comment a little bit. I mean, obviously, I'm not a clinical person at all, but I do know that we, our physicians, or our, the physicians that we have on board in our health plans make sure that the images are done at accredited facilities. So that, as far as looking at the quality of it, I would say we're far from that, probably, to be honest with you. I know there's AI and those sorts of things to look at these, but yeah, we're using the latest protocols, but yeah, I think we're far from doing it. I think there's interest there, but it's something we're far from.
So, we're having, it took time and effort to get our system up and running using the correct reformats. So it takes time, and I think we need a national standard. to do that.
We have time for it.
Ginny, do you want to comment on that?
My thoughts are that the type of, I guess, quality control that you're thinking about, if it fell to a payer, would be more within the scope of the network quality assessment. And then just there's always a tension between network adequacy and access for patients and quality. So those things have to be reconciled. It's quite complex, but yes, I've thought about this a lot, having to do with the quality of bone densitometry. I frequently see bone densitometry data for which treatment decisions have been made that are faulty data because the quality was not there. But then, on the other hand, we don't want to decrease people's access to getting their bone density scans done. So it's a difficult problem. I think encouraging folks to get the proper accreditation is probably the best that we can do.
What I'm hearing is that probably the accreditation organizations would be a better path than the payers. If we can get the accreditation organizations, and the payers will adopt that. We had, I think we're out of time. There was one comment that noted that it's not just United Healthcare that's moving on the outpatient, preferring services done outside hospital or hospital outpatient, but in the community. I would note that there are huge cost differentials in many services where hospitals are charging 100, 200, 300% more than community-based services. So there's of course a couple of sides to those arguments, but we've introduced the idea of some of the payers, what payers are doing to imaging, and certainly there's I've heard a lot of interesting ideas and important work being done in payers, and a lot of interest in screening, and I hope we'll have more discussion in the next sessions of these topics. So I want to thank our panelists and thank the viewers. Thank you very much.